welcome to this session. In this session, we will be discussing about osteomyelitis. Or osteomyelitis means infection and inflammation of the osteoreticular system or the bone. So let's come to our learning objectives. Okay? So first we will see what is the etiology, or what organisms or what causes osteomyelitis or inflammation of bone. Then we will talk little bit about how it happens and who are more predisposed to this kind of infection. Then the clinical picture, or how these patients present, how they are diagnosed, and then the radiology, or how they look like on the radiological imaging, and the pathological findings if a biopsy is performed. Then we will talk little bit about detail in tubercular as well as syphilitic. Both are another bacterial infection. Then finally the outcome and complications of osteomyelitis. Okay? So to set up this session, we will see the first case scenario. So here comes a 10-year-old boy who presents with fever, leg pain and a swelling or abscess on the leg for 2-month duration. So there is fever, leg pain and abscess. On examination, there is a discharging sinus which is detected on the skin of tibia. Okay, there is a discharging sinus with white particulate matter discharge. On investigation, the X-ray showed a lytic lesion corresponding to the discharging sinus. So if we assimilate all the findings, fever, leg pain and abscess or swelling, they are indicative of a infective or inflammatory process. Okay, so we are sure there is an infection or inflammation. Okay, and then there is a discharging sinus. Now discharging sinus can be there in any kind of infection and inflammation. It is not specific for anything. But the most important thing to be seen here is that there is the discharging sinus is corresponding to the bony lesion, and on X-ray there is a lytic lesion. So what does that tell you? There is discharging sinus is corresponding to a lytic bony lesion. Lytic bony lesion, and it is continuous with the bone. So that tells you that the site or the origin of this discharging sinus is from the bone. Okay? And if you compile all this history, and there is whitish particulate material discharge. Now what is that particulate material discharge? They are bony fragments, otherwise called as sequestrum, okay, or dead bone. We will come to the detailed pathology of all this, but here this whitish discharge means there are bony fragments, otherwise called as sequestrum. Okay, so if you compile all this together and then we try to answer our first question, what is the diagnosis in this case? So it is a infection of the bone or bone marrow called as osteomyelitis. Okay, and how it can be diagnosed? It can be diagnosed by a FNAC, or it can be diagnosed by biopsy to know what is the organism causing this osteomyelitis. Okay. The second question, describe the characteristic feature of such pathological process and what are the chronic complications of osteomyelitis. We will be discussing in detail in our subsequent slides. So before we go to osteomyelitis, I would just like to revise your anatomy on bone, or what bone, which are the structures that is important, and what all we are going to discuss. If you see the different parts of the bone, that is epiphysis, metaphysis, diaphysis and medullary cavity. So if you see here, this is the epiphysis, this is the metaphysis portion, you have the diaphysis here, and then you have the medullary cavity that is throughout. Okay, so that is about the parts of the bone. Now if you come to bone, you have cortical bone as well as cancellous bone. Now the cortical bone is present here in the diaphysis to give support or to give strength to the bone, whereas cancellous bone is present within the marrow cavity. Okay? The third part of it is covering of the bone, that is periosteum. Okay? Periosteum is the outer covering, it is a thicker covering and it is supplied through blood vessels, whereas endosteum is the one that lines the medullary cavity. If you see this picture, this is the outer layer thicker, that is called as periosteum, whereas the inner layer which lines the marrow cavity or thinner single layer, that is called as endosteum. Now you have to remember epiphysis, metaphysis and diaphysis, as I will be talking about them in detail during different pathological process. Now let's come to see a few points on osteomyelitis. So osteomyelitis is inflammation of bone and bone marrow. So what are the common etiological types? Now etiological types can be bacterial or pyogenic osteomyelitis, that is the most common subtype. Okay? The second common is tubercular osteomyelitis, though it is also a bacterial infection, but it has very characteristic and different features from pyogenic osteomyelitis, and hence it is separated, mentioned as tubercular osteomyelitis. Rarely we can also have fungal osteomyelitis, especially when the patient is immunocompromised like HIV or transplant. Okay? So altered immunity can lead to fungal osteomyelitis. Now the roots of infection. What could, from where or how these infections enter into the bone or bone marrow? First is hematogenesis. Now suppose a patient has a subcutaneous infection or inflammation or has a sore throat or has an infection or TB in the lung or lymph node. These infective organisms, this is the most common, can spread through hematogenous route or through blood and go to the bone. Okay? Second is extension from contiguous site. This is the second type. Like I said, if there is an infection of lung and there is formation of abscess, and these abscess can drain into the psoas region, forming a psoas abscess, and this can also go into the vertebral column, or it can also extend into the rib. So that is how you have extension from contiguous site or direct extension. The third is direct implantation. Now this is the type of root that is mostly happen when there is a open injury or a road traffic accident. When there is an open fracture or the wound is open and the bones are exposed to outside, so there can be direct implantation of bacteria into the bone, and that is called as direct implantation into the bone. So that was about common etiological factor and roots. Now let's see what are the organisms or specific bacteria that cause osteomyelitis. Okay? So the first common and most common is Staphylococcus aureus, and this is most common. Almost 80 to 90% of osteomyelitis will be because of Staphylococcus aureus. This is a question and you have to remember. The other common bacteria are E. coli, Pseudomonas and Klebsiella. Okay? So Staph, E. coli, Pseudomonas and Klebsiella are the four most common bacterial organisms. Now, though rare, but Haemophilus influenzae and group B streptococci are more common in the neonatal period. Now, this can be a question: which organism is the commonest cause of osteomyelitis in neonate? Then you have to look for group B streptococci or Haemophilus influenzae. Okay, this group B streptococci causes sore throat, and in pediatric patients, secondary to sore throat, there can be hematogenous transmission to the bones leading to osteomyelitis. The fourth is Salmonella typhi, and you have to remember this is very specific, and especially in patients having sickle cell anemia or sickle cell disease, Salmonella is the common cause of osteomyelitis, though Salmonella can happen in other patients also. Now Salmonella is responsible for something called as typhoid fever. Okay, Salmonella typhi causes typhoid fever, that is an infection of GI tract. Now I have spoken about hematogenous. From GI tract the infection goes to blood and it disseminates into bone. Okay, disseminates to bone to cause osteomyelitis. So Salmonella is common for S. For S, you can remember Salmonella for sickle cell disease. That can be a MCQ type question. Next is mixed bacterial infections, that mostly happens during surgery or if you have open fractures. I have already told that there is direct implantation. So this is another method, direct implantation, which can lead to a mixed type of bacterial infection or also fungal infection. Now based on the location and stage, in children most common sites of origin of infection is metaphysis, where it starts and it can go or extend into the epiphysis. Whereas in the adult the metaphysis is less involved and epiphysis and subchondral region are more commonly involved. So if we combine both, then epiphysis is involved in both, but metaphysis is more common in children. That was based on the location. Now based on time and extent. So any infection, when it is like early or manifests early, it is called as acute. And the same infection when goes to a long term or progresses to a long term, it is called as chronic. Okay, so acute and chronic, in between will come subacute. So any infection that's less than 2 weeks is called as acute osteomyelitis, whereas chronic is anything that is greater than 6 weeks, and in between is subacute, that is 2 to 6 weeks. Okay. Now once a biopsy is done, what a pathologist sees, you can see here the bony tissue. Here it is full of neutrophils or acute inflammatory cells. Acute inflammatory cells are neutrophils, whereas chronic inflammatory cells are plasma cells. You can have lymphocytes as well as histiocytes. Okay, so these are chronic inflammatory cells. So in acute inflammation you will find neutrophils, whereas in chronic osteomyelitis you will find plasma cells, lymphocytes as well as histiocytes. In addition to that, we will find dead bone as well as new bone formation, that is called as involucrum. Okay, so that was about acute and chronic, how they will look. Now let's discuss what will be the clinical features of osteomyelitis. So like any other infection, fever, chills, leukocytosis, this is increase in WBC. So this is a common for any infective or inflammatory lesion. Okay. In addition to that, you can have thrombic pain over the affected region. So any bone that is affected with osteomyelitis will also have throbbing pain, and that will not be even responding to analgesics. So, but these are common features to any infective lesion. The next is radiology. Suppose a osteomyelitis is suspected and the X-ray is done, what we are going to find is lytic lesion surrounded by rim of sclerosis. Now this lytic lesion, again the appearance of which will vary with the age and duration of this osteomyelitis or inflammation. Up to 25% cases can progress to chronic infection. So if there is an acute infection, we know it has to be treated. Okay, treated. Once it is appropriately treated, it will resolve. But if it is not appropriately treated, then it may progress to chronic inflammation. Okay, so in acute osteomyelitis the same phenomena happens. So if there is delayed diagnosis, extensive necrosis or inadequate therapy, these three features exist, then the lesion will not heal or the acute inflammation cannot be contained, and that will progress to chronic osteomyelitis. Okay. And once there is chronic osteomyelitis, there is every possibility of fracture and sinus tract formation, that is a discharging sinus, that is a continuation or a tract between the bone and the skin. So this is the discharging sinus through which sequestrum can be seen, as we had discussed in our case scenario. Now, how osteomyelitis evolves, or how the pathogenesis of osteomyelitis happens. Now, there is a bacterial infection and bacteria will proliferate mostly at the metaphysis. Okay? I will come to that later. So, bacteria proliferate at the metaphysis. Then what will happen? These inflammation will spread longitudinally. Now, if you can recall a bone, that there is epiphysis, metaphysis and diaphysis. So, in the metaphysis region, there is this inflammation which is forming a small abscess. It can extend longitudinally up or down. Okay? Then this inflammation now becomes bigger and forms a subperiosteal abscess. Subperiosteal means there is a periosteum. I have already told you periosteum and endosteum. So, below the periosteum there will be an abscess. Once there is a periosteal abscess, what that will do? That will lift the periosteum and that will impair the blood supply to bony tissue. Okay? So, if I draw a diagram here, there is below the periosteum there is an abscess and periosteum is lifted. Now, once the periosteum is lifted, the blood supply that is coming from outside will be affected. So, the underlying bone will undergo necrosis because of lack of blood supply. Now, once there is necrosis, there is lack of blood supply, this rupture of periosteum will lead to a draining sinus or a tract or a sinus tract that we have already discussed. In addition to that, this necrotic and dead bone can be known as sequestrum, and there can be new bone formation in chronic osteomyelitis that will be surrounding the sequestrum, and that is called as involucrum. Okay? So, involucrum is the new bone that surrounds the dead bony sequestrum. Okay? So, that was the diagrammatic representation. Now, let's how it looks here. Okay? So, if you see here, this is the epiphysis and this is the metaphysis region. Okay? In the metaphysis, you can see the vessels are loopy, or lot of capillary network will be there in the metaphysis region. So, what happens? The infection starts here. The microabscess forms, then the microabscess becomes a bigger abscess, and then you see the periosteum is still intact. Later, what will happen? This abscess will rupture and there is elevation of periosteum. Here, periosteal elevation. Once periosteum is elevated, you will have dead bone, that is sequestrum. Oh, because periosteal elevation will impair blood supply, and so that will lead to necrosis of bone, that is sequestrum. In the later stage, this this abscess will rupture to the skin to form a sinus tract. Okay? And then there is in the later part still new bone formation around the sequestrum, that is called as involucrum. Okay? With both the diagrams, I hope your understanding on how the pathogenesis of osteomyelitis or how osteomyelitis evolves is very clear. Now, once there is chronic osteomyelitis, what will happen? There is osteoclastic bone resorption, ingrowth of fibrous tissue and deposition of new reactive bone at the periphery, and this new bone is called as involucrum. Okay? Now, here there are different pictures. If you can see, this is the radiological picture where of chronic osteomyelitis, where the bone is irregular as well as it is like scalloped, irregular very bone, and that is called as dead bone. The corresponding when it is taken out, this is called as sequestrum. Okay? So, you can see this bone when it is taken out, it will look like this, irregular and friable. This is another picture just to show you. This is a dead bony fragment, that is sequestrum, whereas this is the radiology as well as graphical presentation. Here you can make out the sequestrum. So, this is the dead bone, and surrounding the dead bone there is some new bone formation, that is called as involucrum. Now, we have understood how the pathogenesis or how osteomyelitis happens, what are the organisms that cause osteomyelitis, and what are the clinical features of it. Now, we will come to the complications of osteomyelitis. So, what are the complications that can happen? First and foremost is pathological fracture. Now because the periosteum is damaged, so the bone becomes weak, and if that is a weight bearing bone like your femur or tibia, then it can easily undergo pathological fracture. Okay? The second is secondary amyloidosis. Now amyloidosis is a deposition of special type of protein, extracellular deposition of protein, that will be discussed in subsequent chapter, but we know amyloidosis can be two types, that is primary or secondary. Primary is mostly because of plasma cell dyscrasia, whereas secondary is because of chronic inflammation. Now the chronic inflammation can be chronic osteomyelitis or chronic granulomatous lesion like tuberculosis. So what we can find is secondary amyloidosis because of chronic osteomyelitis or tuberculosis. The third is endocarditis. Now endocarditis means inflammation of the valve or endocardium. Okay? So because this osteomyelitis from the bone, it will go to the blood and circulate, so it can damage the valve and endocardium, causing endocarditis. Fourth is sepsis. The patient can develop generalized, or the infection can evolve from one organ and involve multiple organs, and that is called as sepsis. The most important complication from the sinus tract is a squamous cell carcinoma. Okay? So squamous cell carcinoma comes from the sinus tract, whereas sarcoma develops in the infected bone. The bone will develop sarcoma, the sinus tract will develop squamous cell carcinoma. This you may get as an objective or MCQ. You have to remember this. These are the two malignancies, that SCC and sarcoma, that develop in relation to chronic osteomyelitis. Okay? So that was about complications. Now we will look at two morphologic variants that are frequently asked as question. One is Brody's abscess. Now what is Brody's abscess? Okay? These are small intraosseous abscess, usually close or involving the cortex and walled off by reactive bone. So reactive bone is there, inside there is an abscess. And these are difficult to treat because of the new bone formation, the antibiotic cannot penetrate into the abscess, so the organisms will keep proliferating within the abscess. Okay? The second type is sclerosing osteomyelitis of Gare. Okay? And this is because extensive new formation that obscure the underlying osseous structure typically seen in the jaw, that is called as sclerosing osteomyelitis of Gare, and that is typically seen in the jawbone. Okay? That was about some morphological variants of bacterial osteomyelitis. Now with that we will continue to the next case scenario, that is a 46-year-old man presents with fever, bilateral leg pain and weakness. There is fever, bilateral leg pain and weakness. Okay? On examination there is a palpable soft tender lesion around the mid-thoracic region or mid-thoracic spine along the back. Okay? X-ray spine shows a lytic lesion corresponding to point of tenderness with collapse. Okay? And then corresponding to collapse of the T8 vertebra, he also gave history of pulmonary tuberculosis 3 years back. So if we assimilate all these clinical features and our radiological features, the first important point is fever. So there is infection. Bilateral leg pain and weakness. So there is some sort of compression of the spinal cord. Okay? So that we will come later. Now there is a soft palpable lesion around the mid-thoracic spine. So the infection has affected the vertebra. And here you can see there is a lytic lesion corresponding to point of tenderness. So the vertebra is involved with infection and there is discharging sinus, okay, and there is discharging pus, so a soft tissue abscess is formed, and that is felt as a soft tender lesion around the mid thoracic spine. As well as there is collapse and the patient gives history of TB 3 years back. So with this history of TB 3 years back, the most probable diagnosis in this case is tubercular osteomyelitis of the spine, okay, tubercular osteomyelitis of spine, otherwise called as pot spine. So here tubercular osteomyelitis is much more common in the spine as compared to any other site. So if there is a spinal involvement, the first possibility would be a tubercular infection rather than any other bacterial infection. Okay, so that is the answer to our first question. Now describe the characteristic feature of such pathological process. So you have to mention here what are the microscopic features of tubercular osteomyelitis or what you find in tuberculosis. So if you come to the characteristic feature, what shall we find? We will find granuloma, we will find giant cells, we will find necrosis. And how TB is confirmed? Yes, come on. We do a special stain that is called as ZN stain, and it will highlight the acid fast bacilli, so tuberculosis can be confirmed. Okay. The third question, what are the complications? Now one of the complication is already there, that there is compression and collapse of the vertebra which is causing spinal cord compression, and that spinal cord compression is causing leg pain as well as weakness. The other complications we will see in our subsequent slides. So let's have a detailed look into mycobacterial osteomyelitis. Now before going into that, you can see here the picture, the clinical scenario what I described before, that here if you see this vertebra and this vertebra, there is a difference in the width. If you compare all three, then this vertebra has undergone a compression collapse, and that is because of tuberculosis, and this condition is called as pot spine. Okay, so with that we will come to mycobacterial osteomyelitis. This infection is more common in developing countries, so osteomyelitis because of mycobacterium is also common in developing countries. Osseous infection is seen in up to 5% of individuals of TB at other site. If you recall our case scenario, the patient had history of pulmonary tuberculosis 3 years back. So possibly that infection would have got reactivated and now gone and infected the vertebra. So up to 5% patients can have tubercular infection at other sites. It is more destructive and resistant to treatment because it has to be diagnosed properly and then it has to be given the specific therapy. And if you can recall pharma, then tubercular treatment are different, or the duration of ATT, anti-tubercular therapy, is different for bone, for lung, for kidney. So accordingly, these patients have to be treated for almost a year. So these lesions are very resistant to treatment. Spine is involved in almost 40% of cases, and that is called as pot spine. I have already described this. The route of infection can be direct extension from rib or adjacent vertebra, or it can be hematogenous from any other tubercular site, like from a tubercular pyelonephritis or tubercular lung infection or a tubercular lymphadenitis, which can take a hematogenous route and go into the vertebra. Okay, so the clinical features you can see here, there will be localized pain along with low grade fever and weight loss, which is a very common symptom for tuberculosis. Low grade fever and weight loss is a very common feature. Infection is usually solitary, only one site or only one site of osteomyelitis, but if the patient is immunocompromised or HIV transplant background is there, then osteomyelitis can be more than one site or it can be multifocal. The most common site in the spine, that is thoracic and lumbar spine. Thoracic more than lumbar, as well as multiple vertebra can also be involved with pot spine or spinal tuberculosis. And the complication is vertebral compression fracture leading to scoliosis, kyphosis, as well as neurological defects, as we saw in our case scenario. Okay? Knee and hip joints can be involved in case of tubercular osteomyelitis. So this is called as TB arthritis. So this can be a complication of osteomyelitis. Now if you see this picture, this is a H&E stain, and what do you see here? Here there is necrosis, here there is giant cells, and here there are histiocytes. Okay? So you have histiocytes, you have necrosis, you have giant cells. So this is suspicious of a tubercular lesion, and if you do a ZN stain, here you can see the ZN is strongly positive for acid-fast bacilli, or it confirms that the patient has tubercular spine or pot spine. Okay? Now the complications of tubercular spine is psoas abscess. So the spine is involved, and suppose this is the lesion, and this can rupture and lead, or that can lead the abscess or the discharge can come into the soft tissue, that will lead to a psoas abscess. And it can go to a joint space causing arthritis. So inflammation of the joint is called arthritis. So TB can lead to tubercular arthritis in cases of TB spine or pot spine. There can be sinus tract formation. This abscess comes to the soft tissue, it will be an abscess, but when this abscess ruptures to skin, it is called as sinus tract. Okay, a sinus will be formed and pus will be coming out of it, and as usual, like any chronic osteomyelitis, amyloidosis is one of the complications of tuberculosis. Tuberculosis is a chronic infection or chronic inflammation. Chronic inflammation leads to amyloidosis. You have to remember, and it is secondary type, not primary. Okay, secondary. So all these complications you have to remember. You may get a short note or MCQ type in which you have to remember psoas abscess, arthritis, sinus tract, and amyloidosis. After completing mycobacterial osteomyelitis, we will look after another common osteomyelitis of a specific bacteria called as syphilis, or the organism is Treponema pallidum. Now why it needs mention separately is because these osteomyelitis will be morphologically and therapeutically different from bacterial and mycobacterial osteomyelitis. Okay? The site of infection, if the site of ossification is affected, then it is called as osteochondritis, whereas if periosteum gets infected, it is called as periostitis. Okay? It can involve both congenital as well as tertiary syphilis. Now we are not going into the detail of syphilis, that you will learn in microbiology, but it can affect congenital as well as tertiary syphilis. The most common sites are nose, palate, skull, and long bones like tibia. Now you can get an MCQ on that, so you have to remember the sites nose, palate, skull, as well as long bones, which can be affected by syphilitic osteomyelitis. Now, seen in tertiary syphilis, that is mostly 3 to 5 years after the infection. And what will be the chronic manifestation? The most common is Saber-Sheen. Okay, you have to remember, this can be a question. So Saber-Sheen is periosteal reaction over tibia, that is anterior and medial. So there will be periosteal new bone formation in the anterior and medial aspect, that is called as Saber-Sheen. And I have already told you the nose is affected, so the nasal breeze will be destroyed, and so it will lead to saddle nose. So Saber-Sheen and the saddle nose are two chronic, or you can say are seen in tertiary syphilis. So if a biopsy is done, what shall we expect? In HPE, we can expect gomatous lesion, that is a chronic granulomatous inflammation rich in plasma cells, as well as we will find obliterative enteritis, and the presence of spirochetes can be demonstrated by silver stain or immunohistochemistry. I will repeat that again. On HPE, you will find gomatous lesion or granulomatous lesion, goma G4G, and granulomatous lesion which is rich in plasma cells. You will have obliterative endarteritis, or the arteries or smaller vessels will be destroyed, and the presence of spirochetes can be demonstrated by silver stains or IHC, and you can get a MCQ on that. So you have to remember little bit about skeletal syphilis. Okay, with that we come to the organisms, the cause, the complications, the clinical features. Now we will see what is the treatment. Okay, so any type of osteomyelitis is first treated with antibiotic therapy, and if antibiotic therapy cannot contain it, then we need to go for a surgical treatment or bone debridement, especially in chronic osteomyelitis. Okay, acute is mostly treated with antibiotic therapy, whereas chronic is treated with surgical debridement. Now antibiotic therapy again will vary, like you can go for a routine antibiotic for bacterial, you have to go for ATT for tubercular, whereas you have to go to for penicillin for syphilis, and the therapy will be different depending on organism. The general nutritional status of the patient has to be improved, and immobilization may be given to the affected bone if there is a chance of a pathological fracture. In order to prevent pathological fracture, immobilization can be done. Okay, that was about the treatment which is applicable to all kind of acute and chronic osteomyelitis. With that, we will take a few questions in order to have a better understanding of your topic. Okay. So the first, what is the difference between arthritis and osteomyelitis? Now you must be very clear that arthritis is involvement or inflammation of joints, whereas osteomyelitis is involvement of bone and bone marrow. That is inflammation of bone and bone marrow. Be very clear about it. Then you may be asked to write a short note on Pott's spine or Pott's disease. Now Pott's disease is mycobacterial tubercular infection or osteomyelitis of the spine, most common in thoracic and lumbar vertebra. You know the complications, you know the microscopy, so you can easily write a short note on that. Now let's have a few MCQ. Which of the following feature will not be seen in Pott spine? So here we are talking about the microscopic feature. Okay, so giant cells, do we find in Pott spine? Yes, we find giant cell, and that is Langhans type of giant cell. Okay, do we find caseous necrosis? Yes, we find caseous necrosis. Do we find epithelioid histiocytes? Yes, they are present. Do we find pannus? No. Pannus is seen in the joint in rheumatoid arthritis, not in Pott spine. Okay, so here comes the next MCQ. What are the investigations needed to be performed if arthritis is suspected or osteomyelitis is suspected? Okay, so what is the order of investigation? First, detailed clinical evaluation and history. If the patient had trauma, fever, any other systemic infection like tuberculosis involving any other site other than the primary site. Then the radiological evaluation to see whether it is just a soft tissue lesion or bone, it is acute or chronic, lytic, non-lytic, whether there is new bone formation, whether there is involucrum, whether there is sequestrum. So all that can be seen in radiology. Then we can aspirate joint fluid and send for culture as well as cytology to see whether it is tubercular or it is because of any other pyogenic bacteria. Serological investigation to see if the patient has RA or patient has osteoarthritis or patient has SLE. These SLE and RA can show serologically positive factors which can help to suspect and diagnose SLE and RA. So next objective is, which of the following organisms is responsible for osteomyelitis in sickle cell anemia patients? I have repeatedly stressed the different organisms that affect different age group, and in sickle cell anemia I have told or stressed that the common bacteria that causes osteomyelitis is Salmonella typhi, or the organism that causes typhoid fever. Okay, Staphylococcus is the most common, followed by Pseudomonas and Klebsiella, but Salmonella, though rare, is common in case of sickle cell anemia patients. With that MCQ, we have completed our discussion on osteomyelitis. Now we will summarize this session. Okay, so osteomyelitis is an infection and inflammation of the bone. You have to remember that. More common in pediatric patients, but they can be rarely seen even in adult, especially the tubercular osteomyelitis that varies with age and more seen in young and old age. Okay? Most common cause is bacteria or pyogenic bacteria, or Staphylococcus is more common than tuberculosis, though tuberculosis is common, but pyogenic is more common than TB. And on most occasions, this infection is secondary to infection at other sites. Like there is a sore throat. Now sore throat is the primary site, and it is beta hemolytic streptococci. This bacteria will go to blood, and from blood it goes to bone, causing osteomyelitis, and that is what is called as secondary to infection at other sites. Okay? The pot spine or inflammation of the thoracic and lumbar vertebra is common in tuberculosis, and up to 40 to 50% of tubercular osteomyelitis happens in the spine, and that is called as pot spine. All osteomyelitis must be adequately and appropriately treated. The organism must be identified and the infection has to be treated in the acute stage. Once the disease goes to a chronic stage, it is very difficult to contain or totally control this infection and inflammation, and then the complications cannot be avoided. So, the complications associated with osteomyelitis. Now, the most common is pathological fracture, because the bone becomes weak. There is a chance that weight bearing bones will break. So, pathological fracture. There can be endocarditis as well as sepsis because of dissemination of the organism or dissemination of infective organism. Secondary amyloidosis is a late complication, and secondary amyloidosis can lead to many other complications in different organs where it is deposited, like whether it is deposited in the kidney, whether it is deposited in the GI tract or skin or CNS, where it is deposited. Accordingly, the complications will vary. With that, we come to the end of this session. I hope you have enjoyed this session. Thank you so much.